right, so picking up with our cardiac arrest management, we're going to be managing the airways. We have basic adjuncts and the advanced airways as well. And remember, our basic adjuncts are OPAs and NPAs, and they can be used throughout the entire cardiac arrest without utilizing any advanced airway if they are getting good compliance and not meeting resistance. And so that's something that you want to check on regularly and re-ask that question. Am I still getting good compliance or am I meeting resistance? And so a good rule of thumb is to ask that question about every 2 minutes. And so now you can see that we're kind of on a cycle here. Every 2 minutes, we're going to have the AED analyzing. Every 2 minutes, we're going to be switching compressors. And every 2 minutes, we can come in and ask about the airway. And that's just a good rule of thumb. So if you want to lead with a basic airway adjunct or an advanced airway right off the bat, that's really provider discretion for classroom purposes and for real life purposes. Unless your agency has a policy saying that you have to use a basic adjunct first, you could go ahead and lead with an advanced airway right off the bat. But again, you want to make sure that you're still getting good compliance and not meeting resistance continuously. If you are meeting resistance, the very first thing that you would want to do is go ahead and reposition the airway, and that would be with a head tilt chin lift or a jaw thrust maneuver, depending on which airway that you have in and what's going on with the patient. Remember, if they have a potential for spinal damage, then they're going to need the jaw thrust. If that didn't work, then we could progress on to something else. So if you do choose to use an advanced airway, either right off the bat or after you've tried a basic airway adjunct, you're going to want to come in and change that compression and ventilation. And so we talked about that previously, where the compressions and ventilations are no longer at a ratio. So we're dropping the 30-2, and now we're moving to continuous compressions, with compressions being 100 to 120 per minute. And now your ventilations are going to be 10 to 12 breaths per minute, or one breath every 5 to 6 seconds. And so these pictures here are just showing you some examples, again, of those basic airway adjuncts and then the two most common advanced airways that you would see in the pre-hospital setting. If we are using an advanced airway, then we do need to confirm that tube, and there's 3 methods that we can do that with. We're looking for chest rise and fall, we're listening to lung sounds, and then we need to monitor capnography. And so it is a requirement with the Office of EMS that if you have an advanced airway in place, that you're utilizing capnography to confirm tube placement. Now, you can use the easy cap or color change capnography to give you that one time, is it in the right place? But it's not going to give you that continuous feedback like Intitle that's plugged into a cardiac monitor, measuring both the capnometry, which is the number, and the capnography, which is the waveform. So that's really the best way to go if you have that technology available to you. Now let's look at rescue pods. So the rescue pod is an impedance threshold device, or an ITD, and it can be beneficial during cardiac arrest by causing increased cardiac preload and subsequent increased cardiac output. And so if you will just copy and paste this link that's right here on this screen and put that in, you'll be able to open that up and watch that short video on how the rescue pod actually works. So just pause this video here, take that over, copy and paste it in, see how the rescue pod works, and then you'll come back. But it does have a purpose and a place, and as you'll see in the video, you'll get a better understanding as to how that works. It does have a light that will flash about every 6 seconds to prompt ventilation, but that's not the purpose of the device. And then it needs to be removed if you obtain ROSC. So that's going to bring us to looking at reversible causes. Remember, I told you that there are 3 things that need to be continuously monitored, and that is CPR, the use of the AED, and the airway. And then once we've got those 3 things going, the biggest piece from that point is to try to figure out what caused the arrest, and is there anything that we can do to correct that, to, get ROSC. And so we can do that by getting a thorough patient history, by doing a physical patient assessment, by looking at the environment by which they're in. And so all of those things are giving us some clues here as far as what could be potentially causing this arrest. And so these on this list are called H's and T's, and that bottom one that is kind of cut off on the screen is going to be trauma. But so all H's and T's that are listed here, and you can see these in the original PowerPoint that I posted as well. Now, the ones that I put stars beside, and you're going to see that at hypoglycemia and then also at the use of Narcan with an opiate overdose under toxins, those are things that are going to be specific to your agency on whether they want you to treat them or not. We're still talking about them at both a state and a national level, but a lot of local protocols are taking those out because they're saying that the treatment of those things in cardiac arrest should not be done. And I'll tell you just a few examples of those, the hypoglycemia being because you're not getting a good and accurate reading from the capillary beds. And if you're doing everything for the patient, then you're ventilating for them, then they really don't need the glucose at that point. After you get ROSC, if they still needed dextrose, your ALS providers could give that, but that would be something that would need to be provided by an ALS provider in a cardiac arrest anyway, because we never want to put that oral glucose in anyone's mouth. This would be given intravenously. Looking at Narcan in a cardiac arrest, I briefly discussed this in talking about pharmacology and how some things are changing and some people are not giving Narcan when they have an opiate overdose that is an arrest. And the reason for that is because there's some research out there where studies are showing that sometimes when you have the opiate in your system, after ROSC, you're allowing the body to be at rest, much like with induced hypothermia. And so taking that out of the system could have a potentially negative outcome. So again, you might work for a system that says, go ahead and give the Narcan. That's still acceptable at the state and national level in cardiac arrest for where, opiates are suspected or known. But it might also be something that your agency does not want you to do. And so I just want to give you guys the full big picture of things that are being talked about. So again, this whole list is just showing you some things, and I'm not going to go through the entire list here, but I'm going to show you a few examples of how we can look at this and how we can rule this out. So the first one on the list is hypoxia, and clues that we can look for this would be situational in the environment. What actually did they call for? Were they already in arrest? Have they have a history of asthma, COPD? Have they been having difficulty breathing for several days? That type of thing. And we are treating this with the use of oxygen. So when we're ventilating our patient with the BVM and we have oxygen attached to that, we're treating for hypoxia. And so we could move on to the next thing on our list that we would want to consider. So again, you see a lot of these are going to be ALS or higher, and that's okay. There are some things that we could still do at the EMT level, but some things that even would have to be done in a hospital, and trauma, which is cut off of there, is one of those things. When you have someone who has in a cardiac arrest because of a traumatic incident, they don't need really an EMT. They don't even need a paramedic. They need a surgeon. And so our whole goal is to try to get that patient to definitive care at a trauma center so that they can get surgery, because that's really what they need, and that's what's going to save their life. Outside of blood, hemorrhage control and stopping that bleeding, there's not a lot that we can do, especially if the bleeding is coming from an internal source. So I just encourage you to take a look at this list and just read through it and familiarize yourself with what H's and T's are and what some of the potential treatments are, and keeping in mind that our ultimate goal when we are assessing a patient in cardiac arrest is to determine the cause of the arrest, or maybe several potential causes, and then try to provide some treatment so that we can say, all right, well, if that is what it is, I'm providing treatment for that, and we're doing everything that we can. Now, if you do have return of spontaneous circulation, which we would call ROSC, then there's a couple of things you might notice, and one of those would be an increase suddenly in end tidal. So an average end tidal in a cardiac arrest is around 20, and so if it's been around 20 or so the entire arrest and now it's suddenly 40, then that should prompt you to go ahead and check a pulse, because the end tidal, even prior to a palpable pulse being detected, you could see that jump there. So if you check the pulse and you do have one, then you're officially in ROSC, and so remember, they can't be doing compressions when you check this pulse, because you'd be feeling, if they're doing adequate CPR, we should feel a pulse there, okay? So they stop compressions, we've got a pulse, and now what? Okay, ideally we want to wait on scene for at least 10 minutes, okay? And I know that that's a little bit different than maybe what your textbook tells you to do, but on a national and a state level, we want to wait on scene for 10 minutes, because most of the time, historically, if the patient is going to rearrest, it will happen within those 10 minutes. And that way we're still on scene. We still have these resources. We're prepared. So this is not a situation where we want to get off scene as quickly as we can. Yes, we will be providing rapid transport to an appropriate facility. And generally an appropriate facility is going to be one that is able to do cardiac catheterizations. But we want to wait about 10 minutes on scene. Now, in the time period of that 10 minutes, we can go ahead and get a post-resuscitation 12 lead. Even if our ALS personnel is not here, we can go ahead and get it. We can send it to them through our cardiac monitor if we have it. We can send it to doctors at the hospital so that somebody can take a look at it and let us know what's going on. We want to get a full set of vital signs. Up to this point, vital signs other than pulse were pretty mute because we really didn't need them. Now that we have a pulse back, we would have a blood pressure, so we would go ahead and check that full set of vital signs. We want to package the patient, and we could backboard and use a C-collar here even if we don't suspect a spinal injury, because that C-collar is going to help hold the head steady to keep that airway the way that it should be. And the backboard is going to provide a firm surface behind the patient if they do rearrest, so that all we would need to do is pull over and begin CPR. We don't have to fumble around, get in the back of the truck, get in the side compartment, get a backboard out, or even a short backboard. This is going to give us a really quick access to restarting CPR if we need to. And then the last one here is considering induced hypothermia, which is protocol dependent. And so you would want to look at your agency's protocols. If you are going to induce hypothermia, then you probably need ALS there, because they are going to administer some cold fluids to aid with this. But we can start the induced hypothermia process by placing cold packs at the patient's neck, armpit, and groin area to lower that temperature. And so this is called targeted temperature management, and you're trying to get the patient's temperature down, depending on what protocol you're operating under, down to under around 95 degrees. And then you're going to be transporting. So like we said, most likely we'll be transporting this patient to a specialized facility that can do that cardiac catheterization. If the patient is really unstable and they keep rearresting, then we might need to consider transporting to a local or closer facility just to get them stabilized. But usually we're going to be transporting to a specialty facility, and usually that's emergent transport, or code 3 with lights and sirens. Okay. So that's it for this PowerPoint. As always, if you guys have any questions related to cardiac arrest, the biggest piece of this was kind of introducing you to how you put all these pieces together. You've learned how to manage the airway, you learned how to do CPR, you know what the AED is, but putting all of these pieces together to get some type of functionality. And once we're able to get back together and start practicing some scenarios, we'll be able to see this done, and hopefully it will make a little bit more sense to you guys. So if you have any questions about this PowerPoint or any other, please feel free to reach out and let me know.